Hi, everybody. Oh, we've got the AI note takers coming in.
Oh boy.
Hi, everyone. Yeah. You'll be forever remembered in these AI note takers. Welcome, everybody. So glad to see you. We'll just give it a minute for people to come in. I'm so excited to be able to offer this to you all today. Really exciting that David's taking the time to come and talk to everyone. I know this is such an important topic. Hi, Gladys. I'd love for you guys to say hello in the comments if you'd like. Love to see everybody here. You're welcome, Brooke. Yeah, morning, everybody. So we've got a ton of information, and I want to just kind of get into it. I'm Kim Tolson. I am the founder of a billing membership program for therapists called Bill Like a Boss, where we teach therapists how to bill insurance in their private practices. We also teach virtual assistants and admin assistants to do the same thing. And usually every quarter in Bill Like a Boss, we host webinars like this, and they're usually just exclusive to Bill Like a Boss members. I don't open them up to the public a lot for free like this, but I just felt like this was so important. I get these questions all the time, and I met David. He actually helped me. He's my lawyer. He helped me write a contract for a partnership deal I was trying to negotiate, and it was super helpful. And along the way, I was like, I wonder if David would want to do a webinar about insurance billing and helping with all these like really obscure questions, the gray area questions that I get probably like 3 times a week inside of Bill Like a Boss, and even in the free insurance billing Facebook group that I run. So I asked David, I was like, here's all these just weird questions that everybody always has. Could you answer them? And he said, absolutely. So David, I don't want to spend too much time talking about all of that. I want to turn it over to you because I know you've got a ton of great content, and you guys just feel free to put questions in the comments. We've only left an hour for this. David is available for consults after this. If anybody wants to reach out to him privately and have a consult with him. But I'd like to just jump in. We'll try to get to some questions at the end. And David, I'll turn it over to you to introduce yourself and get started.
Well, thank you, Kim, and thanks for hosting all this and getting it all organized. Hey, everybody. Audio is okay? Coming through good? Great. So what I will do, I'll do a little introduction. I'll do my presentation, and I think Kim will be sharing the presentation. So I will admit, despite my best efforts and the use of my own VA, some of the slides are a little wordy. And so I think that'll be good for somebody reading it, but maybe not as nice for somebody who's viewing it. So if I'm going a little fast, don't worry. I think the presentation is going to be sent out, and I'm doing that purposely so I can leave some time at the end. Usually in these types of presentations, I'll start sharing here. I usually do a lot of background, and I kind of spend some time on slides talking probably just about insurance billing in general, but I took a different approach this time. Kim was nice enough to, I think, source a lot of questions straight from some of you, probably also ones that she's also heard over the last, just in her own work. And so I'm actually going to use those as the basis for the slides. And so you may, if you put in a question, you may see your exact question pop up on one of the slides, but I didn't, note who sent it or anything like that. But I hope that that's a good format to go with it. So yeah, I'm David Holt. Owner, founder at Holt Law. We're now in Minnesota and California. Just expanded out to California largely because I don't love Minnesota winters. I was just born here, and I've been trying to escape ever since. So I do snowbird down in California quite a bit, and the practice is completely virtual. So I have the opportunity to do that. We only do healthcare and business law. We don't do anything else, and so we do get a lot of mental health professionals, therapists, and unfortunately, a lot of insurance type questions. Can we do this? Can we do that? This is annoying. What about that? And a lot of it is gray, but I'm going to try and shed as much black and white light as I can. And let's just jump right in. I'll click over here. All right. So just a quick disclaimer, just cover my butt. Obviously, this is educational in nature. I'm not your attorney unless we, separately contracted to be together. And so this information may contain errors and may become out of date in the future. and you're relying on it at your own risk. And I'd advise you to invest in competent legal counsel. All right, so as advertised, I'm going to go straight into questions that were sourced to me, and then I may go off on a few tangents. I think the best way, and Kim's probably monitoring the comments, is I will circle back midway through the conversation based on questions that are directly related to the first set of slides. And then at the end, I'll take questions on the second set of slides, plus anything else that you want to ask, and I'll do my best to rifle through them. I actually can't see the comments right now, so I'll let Kim decide if she will pop in and stop me for a quick sidebar. Okay, so let's talk about we're in network with an insurance provider, right? We've signed some sort of contract with them, right? With the insurance company, Blue Cross Blue Shield, what have you. And so we have to abide by the terms of that agreement, right? Sometimes the agreement is silent on issues. Sometimes it's not very clear, or you're getting different advice from different people that you talk to. But the four corners of the contract are always going to be what governs any individual situation. So usually I'm speaking in general terms, and I did see a lot of mention of Blue Cross Blue Shield when the questions were being sourced. So there are times that I reference Blue Cross Blue Shield, and also I did try to pull up, in case we have time, way at the end, a Blue Cross Blue Shield provider manual and a sample payer contract. Okay, so are we allowed to limit the number of slots available for clients or patients with a specific insurance if we are an in-network provider? Yes, but see your payer provider insurer agreement. So Blue Cross Blue Shield specifically will allow this. I'm basing it off of a Minnesota Blue Cross Blue Shield contract and provider manual. And so this is, you need to be careful here. It needs to be for operational or business reasons. We're not doing this because we don't want, a certain race or gender or something like that. That's pretty obvious. But legitimate business, hey, my schedule is at capacity. I simply cannot take any more. That would be reasonable. What usually happens here, though, is we're getting a significant amount of Blue Cross Blue Shield, but then you make a business decision that you want to, yeah, that's a good source of revenue, but we really like the private pay, or we really like something else. That's fine, but we want to phrase that as an operational or a staff challenge, not a business preference to target only the private pay patients. So that's how we would navigate this one. I'm just going to set a pretty aggressive pace here to get through these. So how do we know if we're violating any anti-discrimination law? High level, it's going to be race, sex, disability. At the federal level, Minnesota and California do expand that a little bit. Age is in there, a few others, pregnancy, I believe. But really at the end of the day, not only are we trying to be compliant with state and federal law, but we want to also teach that to our staff or those who are working underneath us, whether they are clinical or administrative in nature. And again, it's reasonable to manage appointments for business needs. Like, hey, my practice is growing like mad. I just do not have any slots. That is very different than, hey, just not feeling like serving a certain, type of individual, clearly discriminating. There are some interesting ones in between that I'll get to on later slides. Again, I apologize, the text is a little smaller, and that is so that when we send this out, it serves a little more as a desktop reference. Okay, sliding scale flexibility. So as therapists who also bill insurance, are we permitted to offer a sliding fee scale structure for clients paying out of pocket? You can't charge an insured. So I'm assuming that I'm insured. I have Blue Cross Blue Shield. You've signed a payer contract with Blue Cross Blue Shield. I show up and we're using that insurance. You have to abide by the amounts that are listed on that fee schedule and in that contract. And note that a majority of these contracts, specifically the one in Minnesota, has a provision disallowing you from waiving or reducing copayments or deductibles. you would need a blessing from Blue Cross Blue Shield and provider relations or something in writing to be able to do that. And I'll just say from experience, when you get into, asking for those exceptions, it can be a very, time consuming, frustrating, complicated, and just not really reimbursed for your time type endeavor. So general advice is just going to be follow the parameters of your insurance contracts. But I'll tell you about a workaround a little bit later. Follow-up question to this is, where would you find this in the insurance contract? What do you look for and who do you ask? Now, any of you who have looked at one of those insurance contracts, and let's see if I can just bring one up on the screen. We'll see if this one will pop up. Is that one popping up there, Kim?
Yes,
on the screen?
I can see it. I
yeah, so I mean, this isn't fun to read, right?
Yeah.
And not everyone's gonna, let's be honest, not everyone's gonna hire an attorney to actually go through and understand every little spot of this. And just to make matters worse, oftentimes that contract references a bunch of other, this is, for example, the Blue Cross Blue Shield of Minnesota Provider and Policy Manual, which, nearly all providers, granted, there are a lot of provisions that are only applicable if you're, a birth center or what have you. But, this is just a lot of information to go through. And so what I would say is, if I had to do a little control F or trying to find a term in a document, the things that the buzzwords that I would be looking for would be billing practices, fee schedules, or co-payments and deductible waivers. So those would be the control F terms I would do. Also, I don't think Blue Cross Blue Shield is necessarily the most, user-friendly as a provider, but sometimes you can get some good provider reps on the phone that can guide you through where things are in the contract. They're not really advising you from a legal perspective, but they can at least point to what they believe the rule is. Mixed results on that. Just gonna make sure I hit everything on this slide. Yes. And then also getting clarity on the sliding fee scale policy, but I'll teach you a workaround in a different slide for how to basically turn an insured patient into a self-pay patient strategically in some situations. Let's move on that one. Okay. So whenever I hear sliding fee scale and whenever I sometimes see it used in practice is, you have a contract. I'm just going to keep using Blue Cross Blue Shield. We're the provider. We've signed the contract. If somebody walks through my virtual or, real office door with a Blue Cross Blue Shield, insured card in hand and says, I want to use my insurance, we generally would not be allowed to use a sliding fee scale to then turn around and say, well, okay, well, Blue Cross is going to pay this, but we're actually going to look at your financial situation and discount that a little bit. Without express written, well, I would like written approval from Blue Cross Blue Shield. So the way around this is, and there are situations where this could be a better deal for the patient, not always, but, and also we need to think about you making money. And, there's in legal, we call it, pro bono or for free or low bono. So, reduce rates. And I certainly can appreciate providing that. But at the end of the day, if you do too much of that, you're not in business, and then, no one wins there. But you can have a patient convert from an insured into a self-pay or uninsured patient. So even though I have that Blue Cross Blue Shield insurance, I have a federal right to say, you know what? I don't want to present with that here. I would like to just show up and deal with you one-on-one directly as the provider. And therefore, they're choosing, the patient is, you wouldn't really force them into this decision, of course. They would choose this on their own because it's a good economic decision, and they would become a self-pay or uninsured patient, which means they're making the conscious choice to present without their insurance, which they are allowed to do. The insurance company cannot get in the way of that decision as long as it's theirs. So now at this point, we can do whatever we want, well, without discriminating. So the sliding fee scale could be in play. And usually the sliding fee scale that's non-discriminatory would be the one that's based on financial ability to pay. And that allows a patient who does not have as much money to still pay something, but not as much as they might pay if it ran through insurance and they had a copayment or deductible or what have you. So it is a creative way to get around it. Although when you're doing the math at the end of the day, we just want to be smart on what we're getting versus what we're giving away, if you know what I mean. And there may be a lot of reasons why you would do this. It's quicker revenue. So, right, we're not billing out to insurance and then waiting for it to come back. It's just, boom, we're getting some cash effectively right at the time of service. And for those who just don't like dealing with insurance in general, if you have patients that are like, hey, my deductible is massive. There's just no way I don't even know why I have this policy. Let's just you and me do this. And, I'm making okay money, but not to pay your retail rates that you have on the door and on the website. But it looks like I fit about right in the middle for that. That would be a non-discriminatory way to do this. Okay. New subtopic is going to be billing discrepancies and the use of superbills. So can we bill a client an out-of-pocket rate that is different from what we charge to insurance companies and provide them with a superbill for insurance submission? The conservative advice is no. And so the easy way to think about this is that think of yourself as a seller of goods, maybe online, right? You're Nike or something, you're selling the shoe. So out in the world of retail, there's really only one price, but depending on which route you go through, maybe you get a discount, you get an online discount, you have a coupon code, or maybe you buy it in a different state and it's cheaper or what have you. But in general, the retail rate for a Nike shoe is going to be X. And so that is your retail rate for all of your services as well. You should have a fee schedule, and you should make that fee schedule without considerations for insurance and without considerations for, in general, in my opinion, ability to pay of your patients, and more what the fair market value of your services would be, which is generally higher than what you think it is. And so that's your retail rate, or I like to call it the rate of a very affluent patient, kick down your virtual door and they just had a handful of cash and they wanted to work just with you or yourself. What would be the rate that you would charge if you weren't being shy about it? And so we're not technically charging different rates to insurance or everybody else. It's just that I might charge insurance $100, but they're going to give me pennies on the dollar and I only get $30 back. But that's very different than, trying to sync my retail rates to what insurance is reimbursing. In fact, I would argue that that's a way to, kind of short your practice a little bit on money because you're effectively just running your rates down and using the insurance rates as what you think the market would pay. But I would argue that's not what the market would pay. Okay. There are some exceptions to this, but that's a pretty picky analysis. You'd want to be careful. And at the end of the day, we're trying not to jeopardize our insurance contract here in these examples with Blue Cross Blue Shield, because, if that goes, the patients go with it. So, okay. Medicare, Medicaid, always fun to talk about. So you can't charge Medicare, Medicaid clients a very similar analysis to the previous slide. We're not charging a different rate, but you sure as heck are probably going to be paid a lot less than that retail rate. If we're enrolled in Medicare, we're going through Medicare. The only exception would be non-covered services. And even then, we need to give clear notice to the Medicare recipient using an advanced beneficiary notice. I don't go into that a lot in this presentation, but effectively it's a nice little waiver that was created by federal CMS for Medicare use. And it tells the patient, hey, listen, this isn't covered. Here's why it's not covered. Do you agree that you still want to pay? And even then, there may be some rules about first billing Medicare, waiting for a denial, and then turning around and working with the patient. Medicare is and sometimes Medicaid are just very annoying to deal with. I think the rules are very misunderstood. But as a general rule, If they mention Medicare, we're running it through Medicare is the conservative, easy advice if we don't want to dig into all the exceptions. Same with Medicaid. Medicaid does technically, in Minnesota, they actually have a really nice advanced beneficiary notice. I see it used sometimes for therapists who do a little bit more, I would just call it like coaching, health coaching. It's not therapy, but it just doesn't fit into the billing codes. For some reason, the Medicaid patient does have money. Generally, I see these as a result of separations, right? One of the spouses does have money. It's just not included as part of their income. And they're willing to pay, even though they have Medicaid, they're willing to pay for that kind of these non-covered services. Those are allowed, and they're very similar to Medicare. There's also an advanced beneficiary notice that says, why isn't this covered? Well, this isn't a recognized thing that Medicaid thinks is medically necessary, but you as the patient get to decide what you want to do with me. Here's my price. Are you okay with that? Yes, I am. And then you can charge and get paid for that. Violations, obviously, not only would be paying back money that was billed, but also exclusion from Medicaid, Medicare, and in very extreme situations, allegations of very public fraud, waste, abuse.
And David, we get that question all the time, and somebody even posted in the comments, is it okay for Medicaid to choose self-pay? We just get that asked all the times, and usually the answer is, it depends on the state, but I'm just curious if you have any thoughts on that. Like, can you just charge a client self-pay if they don't want to use their Medicaid, for example?
Yes. So, and maybe by the end, I'll circle back and pull up Minnesota's advanced beneficiary form and show you how I would fill that out.
Okay, that's great. Thank you.
Let's go here. Okay. Medicare Advantage. I mean, Medicare does not excite me. It's not why I get out of bed in the morning is to advise on Medicare, but there were questions about it, so we're going to include it in the presentation. So if a clinician is in network with Medicare, but not with a commercial Medicare Advantage plan, can the client pay out of pocket for services? Likely, yes. Generally legal for a patient with traditional Medicare to pay out of pocket for services. The safest route, though, with the annoying world of Medicare is to actually bill the Medicare Advantage plan, receive a denial. It's like an easy way to confirm, and then receive payment out of pocket from the patient. Now, there's a lot of reasons I would not want to do that because I don't want to carry patient balances if I don't have to. I'd rather just know the answer. But let's say I wasn't, engaging an attorney or didn't want to go through this, complicated legal analysis. I wouldn't call it plain dumb, but I would call it plain safe, where you send out the claim, it gets denied. Okay, now you kind of have your answer. So that's the safe advice there. Also, this I think was a follow-up from the other one. My understanding is that we are not allowed to accept cash pay if we aren't a Medicare provider unless we have officially opted out of Medicare. Is that correct? Yes, that is correct. And then I go into, non-participating versus non-enrolled. I think this is a good one that just goes out with the slides just so that I can stay on my pace here. As I know, not all of you are probably on the Medicare question train, but hopefully for that person who answered those questions, I have some nice text in here. I just don't want the rest of us to go cross-eyed. Okay, variable billing rates. So what are the legal considerations for setting different billing rates for different services, clients or services within the therapy practice? You basically asked the question that was answered before in a different way. So we want to think of it all as just a retail fee schedule, okay? And so we have our retail rates. This is generally higher than what you're billed by insurance. In fact, I would say that's a good way of setting your retail rates is it should definitely be higher than what you're reimbursed by insurance because they're trying to pay the absolute legal minimum that they can. And so that is the allowed amount. So if I bill 100 and they give me back 40, that's not illegal or anything. That's just because my services are worth 100, but I've contracted with the payer that since they're going to basically send me some business, the Blue Cross Blue Shield patients, and we have a group rate, they're getting group discount, right? It's like the whole concept of insurance, but that doesn't mean that you need to lower your, you as a business choosing your rates right out of the gates to match their reimbursement. You got to be careful if you're going to set different rates for different clients and different services due to the anti-discrimination rules. And then also, again, if insurance company, right, Blue Cross Blue Shield sees that you're charging their insured one rate, but then also I come in the door as health partners or, cash pay and you're charging a different rate, that would be bad unless it came in through a sliding fee scale, right? That's really the only way that would work. So we're not charging Blue Cross Blue Shield $40 and then, people who come in self-pay $100. We charge them both $100. It just so happens that Blue Cross Blue Shield pays pennies on the dollar. The No Surprises Act, I'll, quick aside on that. We do want some sort of notice that says, hey, No Surprises Act, it exists. We're going to tell you how much things cost. I was actually a fan before the No Surprises Act came out to tell my clients, just create a nice fee schedule for all your services. And don't just put it on your intake form, put it on your website. It's going to be very difficult for somebody to say that they didn't get notice of your fees if it was both in your intake form and on a website, because most stuff nowadays is telehealth. So, the website is really the point of notice and point of contact. And that satisfies your good faith estimate unless you sell your services as like a bundled, I'm just thinking of a therapist, right? Therapy can take 15 different directions depending on what happens, right? So I don't think it's not like surgery where I know how much the surgery is going to be roughly as long as there aren't complications. That's very different than therapy, which could be a lifelong journey and take a lot of turns that we just can't estimate correctly. So the good faith estimate would be what each session would cost, and those prices should be transparent. And then just following your contract. Okay, it's fine. I think this was kind of answered in a different way, but again, I was trying to copy almost exactly the way they were worded. So is it permissible to stop accepting new clients for one insurance carrier while continuing to accept clients for another, especially if the reimbursement rates and client demographics differ? Yes, so long as you're in compliance with your underlying contract with the insurance carrier. Now, if they're smart, they probably put in provisions that you are not allowed to limit, and then they say a bunch of reasons when you can and can't limit, right? So it's all going to come down to whether there's an actual provision that specifically allows this. Kind of back to my theme at the beginning of the presentation, I think you could get creative, and I could think of ways where some of my contracted staff take Blue Cross Blue Shield, and we just don't have enough to keep up with the demand. Others do not. Therefore, when patients are calling our front desk, it's simply a business workflow issue. This is not we don't want Blue Cross Blue Shield. It's simply that we do not have the business capacity to accept them. That's usually a very good reasoning. Now, we got to be a little careful if we love the reimbursement over at Health Partners, but we hate the reimbursement over at Blue Cross Blue Shield, and we're letting the Health Partners through the door pretty aggressively. That's when we need to have a little peek at the provisions, because there could be. Hence why I qualified my yes there.
That's the question we get a lot. Like people will panel on low-paying panels like Cigna, and then they're like, I don't want to take any more Cigna people. I just want to take the Anthem people, because it pays like twice as much. But people, ask that all the time. So it's a huge issue. Thanks for answering that. Mm-hmm.
I usually, it comes back to more of really a business question back to them is, what are we trying to build here? And do we consider leaving Cigna or coming back.
Right.
And sometimes, depending on how long you've been in network or whatever, you come back and say, we're looking to terminate this contract unless the rates are increased. Probably not as
Exactly.
much sway with smaller practices and most of my traditional clients, but hey, I mean, if you're on your way out, it doesn't hurt to ask.
Mhm.
How would you get this information about limiting patients from one insurance carrier? So the clauses that I would be doing my control F on the provider manual and the payer contract itself, assuming I wasn't calling up the provider resource center and having them kind of try and help me through it, is provider obligations, access requirements, and notification procedures. And so this would talk about, limiting new client intake, when we can do that, when we can't. Okay. This is an interesting one. Can a client who initially opts out of insurance coverage because of a high deductible later opt in after meeting their deductible, particularly in complex situations like ongoing divorce proceedings? So maybe, right? My initial gut answer, kind of operating both as a business owner and as an attorney, would be, I say we bill it and see what happens, right? But set the expectations very low for that patient or client. And the general rule is we want the patient or client to choose whether they are in that session as a self-pay or an insured before the session begins. We're not retroactively choosing when we're in self-pay and when we're in insured land, right? So in a perfect world, claims should be submitted as they're incurred. But retroactive coverage is sometimes allowed if it's billed within the timeline. What I think you can probably get into issues with, though, when I was thinking about this, like the money, you probably already collected the money, if I had to guess. And so now you're asking for payment back so we can submit it all to insurance and see what happens. So we want to be pretty careful there. That have to be very well documented. And yeah, I mean, it's a yellow flag. I'm not saying it's outright legal, and I certainly can appreciate insurance switching pretty quickly and even retroactive insurance in an ongoing divorce proceeding. What I would have is some sort of internal memo that outlines, why this timeline and why you made the decision that you did and how the patient, was going through the divorce and their insurance switched, and, really outline why you're doing this and not just a, big old massive batch of claims that the Blue Cross sees, and they're like, what the heck? Why did these all come in at once? And what's going on over here with this provider? So that's how I would approach it. Is there any restriction on if you opt out? Can they opt back in whenever they want to? Yes. Should I just start this with yes? They generally have the flexibility to do that. This should always be documented in writing with an opt out or opt back in written form. So the general assumption is I walk through the door, I'm in. I don't need to opt in. I just hand you my insurance card, so I'm insured. If I opt out, that's saying I'm not going to use my insurance. So now I'm paying you cash at your retail rate or your sliding fee scale, whatever you may have. But I also want an opt back in form if they start changing their mind. And so we have dated signatures on a little form that makes a nice timeline of when they made their decisions and why. Okay, so private pay for extended sessions. So are we allowed to accept private pay for intensive sessions, such as those exceeding 90 minutes when insurance companies do not cover them? Likely, yes, but providers should be cautious to follow the contractual requirements, including informing the patient of the non-coverage and obtaining their consent to pay out of pocket before rendering services, not like whoops, forgot to, we went over. I know we were in the heat of the moment there, but hey, we got this block. What you probably do, if I were the therapist and business owners, I'd probably eat the first one of those, so not bill. I'd alert the patient, listen, I check the coverage where we only go up to 60 minutes or what have you. Anything above that, here's what it looks like. Here's what it would cost. Very transparent about that. Get an updated consent form if that's not already in your consent form. Very clear about 60, 90, whatever, and that should be good. So it's not going to be covered. You basically turn into a self-pay. The issue or the rub with insurance versus the providers, which goes back to the the start of insurance is, why are we doing it? Is it medically necessary? Should this be extended? And so another thing that I would have in the medical record, just to really cover your behind, would be why did we have to extend? Well, this is going on. The patient was going through this. This was very valid. Bummer that it's not just included by insurance, but here is why I did it. This is not just a workaround for me to try and make more money and juice it out of the patient, which of course it isn't, but I would just make that very clear in the medical record too. Medical record, slightly different than the actual billing of the claim, but interrelated if we're under an audit.
So David,
Okay.
the question we get all the time about this, and I know there are a lot of people in here doing intensives, is it okay for me to have an insurance-based private practice and then start a separate business or practice where I do not accept insurance and run services through that entity as a private pay clinician? So a lot of therapists on here they're trying to do intensives, but they're running up against this problem with these extended sessions, and the insurance companies all have different rules about how you can bill for it. So what they're trying to do is just start a completely separate business entity and not be credentialed with the insurance companies through that tax ID over there, and then be able to bill these extended sessions as private pay. And I'm just curious your thoughts on that, or suggestions around that if people are doing that.
Yeah, allowable. I think I have another slide that says it's okay.
Oh, okay. We got another slide. Okay, good.
Yeah. Was there specific? You're asking about industry trends. I couldn't say how many, I would say see doing that, but it's allowable. It's going to be, yeah, go ahead.
And somebody's asking, do we need like a different tax ID or separate website if they want to do that sort of separation in their businesses?
Yeah, it would be a separate legal entity in a perfect world. So that'd be a separate tax ID, separate branding, separate website. Make that very clear. I'm actually not as worried about the separates for intensive in one and not in the other. It would be more so from the attorney or legal perspective. It'd be the intake. So being, hey, not covered over here, might have been covered over there, partially covered. And then I'm actually more concerned, depending on the license type and the state that they're in, as to like dual relationship or any other self-referral type rules that may exist. So that's more so the things that we're quick checking on and making sure we're okay.
Interesting. So you're saying like a clinician wouldn't say, hey, I could see you actually over here in my other business, but if they just find you through the other website and the other business, then that's okay to do private pay over there that way.
Yeah. So there's a lot of things that could be in violation at the where the intensive's not covered, that organizational one. There also could be non-solicitation, confidentiality, non-competes that are lingering from before, that are grandmothered in. So those, in addition to dual relationship, self-referral, and just general considerations as to circumventing one place where things could be covered and putting to another. It's just a little bit more of an analysis, but by itself, absolutely allowable, high level. Like, can you do it? Yes. Is that model legal in your circumstances? Will depend on just a little bit more of a kind of cutting it through what kind of license you have and a few other things. This was an interesting one, maybe an elaboration about somebody was told, just to summarize here, that Blue Cross Blue Shield wanted them to bill 3 of the same code and get denied before billing the client for the remaining time. Very interesting response, but if they were told that from Blue Cross Blue Shield does have the ability to write its own rules. So that's at their discretion. And so if I was told to do that, I would probably go along with it and get the 3 denials. And I would certainly get whoever told them this in writing, or I would record calls with the provider rep center. So yeah, I don't see anything that's not legal about what they were doing here.
That was actually me, by the way. I had my
Okay.
Blue Cross Blue Shield representative, and that's what she told me. She said, you can't just like, charge out of pocket for stuff like this that won't be covered. But if you bill it, it gets denied, then you have room to charge the client for services that weren't covered by their insurance. Yeah.
Yeah. And this
But
one will be really
I was going to say every Blue Cross Blue Shield, just for everybody listening, is different. So you have to check with that state and your contract and all of that. And don't just go what I just said. Don't go on that alone.
Yeah. This new slide here is actually the answer to the, can I do a group practice versus or whatever, one practice, take insurance, the other one not? Yes, you can. So that is allowable. Just want to be very clear with the patients, and then the previous considerations about, referrals, fee split, that kind of thing. I am at a halfway point check-in. I'm a little behind, but we're doing some good questions here. Were there, Kim, any questions that were related to the first batch of slides before I move into the second half here, and then hopefully leave some time at the end too?
Yeah, there's tons and tons of questions, actually. I think we pretty much covered the first part with the Medicaid, the Medicare, the intensives, how to bill for that. Let's see. Yeah, and then there's just lots of other kind of random questions that we can ask at the end.
Okay.
Yeah.
Then I'll keep going. I'll set I'll go from a jog to a sprint, knowing that we're all going to get a copy of this later, and then we'll open up at the later, since it looks like we're about 20 minutes out from the end. So I will talk. I mean, some of these are repeats. It's just said in different ways. So I'm going to go faster if it's a repeat. This is what the best practices for documenting the rationale behind limiting slots for a specific insurance carrier. I would use the buzzword, and hopefully it's true, of business operational limitations. We just do not have the operational capacity. We're not hiring fast enough. We're implementing a new software, something of that, and have that documented, as opposed to, I think there was suggestion of, probably ramping up Sigma, or ramping down Sigma and ramping up a better payer. Are there best practices for documenting the rationale behind limiting? Yeah. So I would keep, it's a general rule. So yes, you should have policies, maybe a little internal memo that you can reference, signed and date. I would also, anytime you're communicating with a payer, to keep those communications and try to get it in writing, or record the calls that they're recording. The calls, you should be able to record the calls too. And so anytime you're on a call with a provider rep, there's plenty of free apps out there, and you can announce, just like they do, I'm recording the call too. Okay, great. That now we're on the same page, and we have something to reference just in case we get different information later. So document that is really the answer there. That's really the same question. It was just I'm extending. Again, here's some other buzzwords: clinical urgency, appointment availability, or geographic considerations. I think geographic would largely be a, in-person versus telehealth type consideration, but that is one there. Sliding fee scales out of pocket. How can therapists clearly communicate sliding fees policies to avoid confusion and disputes? What documentation is necessary to support these? So we have our high-level sliding scale policy. It's probably just one page. It says, what our income breakdowns are. You can do income verification. I'm just not a fan. I think self-attestation is good enough. And we'll just assume that our clients aren't committing fraud, just because it's annoying to have tax or really anything in there. So I'm just not a fan of holding that information, and it just slows down the process. Maybe you're trying to slow down the process to make it like they got to be committed. Okay, so maybe that I think I could maybe get behind that. But somebody signing and saying something and that not being true, that would be fraud. So it's a pretty high standard to do to get a reduced rate. Fee agreements, so it is just your intake documents plus the sliding fee scale. We want to apply this uniformly, so we're not having a receptionist or stray emails of us allowing some certain types of people to get discounts because we, want to, give them a discount and we feel that we should. And then just communication log. So everything in writing would be ideal. Okay, billing clients out of pocket and using Superbills. So Superbills, I mean, really, put all this information on there. I think there's really no over documentation in a Superbill. I'm just gonna skip down to the bottom here. Also assume that every Superbill service is under extra scrutiny, so make sure the respective medical record is clean. So the bill, a little bit separate than the medical record itself, but since we have a situation where the client is submitting to try and seek reimbursement, I would like to think that this has a higher chance of an audit. Medicare Advantage for the individuals that ask those questions, just note that the presentation will be sent and have some more information about those. But I am going to, in the interest of time, skip through those so I can answer some of the live questions. Different rates for different clients. I think I'm just repeating myself here. I won't, non-discriminatory. This was a different one though. Can I adjust rates for telehealth versus in-person services? Generally, no. Think of a telehealth as it is the in-person, it just happens to be remote. It's the same service, but it's remote. It would also go against, the rules that we have put upon the payers that they have to reimburse it the same as in person. So if you were jacking it up, unless there was a exception, a modifier that allowed it in some weird, we saw some of these kind of during COVID, but generally no. You think of that as the exact same. Good faith estimate. I'll just, the No Surprises Act and good faith estimate. I think there's a little confusion around this. So it's really just a one page, maybe a little bit longer form stating you have rights. It's pretty templated, especially in Minnesota and California. I doubt there's a lot of balance billing going on with this audience, but if you did balance bill, you would talk about that in there. You also say that they can complain to the federal government after they've called you and tried to resolve stuff. But the ultimate defense mechanism to a No Surprises Act or, hey, I got a surprise bill is just having your fee schedule on your intake and your website. It's like ordering off a menu at a restaurant. I know exactly, unless it's a really fancy restaurant, I know exactly what the price of my, meal is going to be before I commit to it. I get the bill at the end. There should not be a surprise unless they screwed up the bill, right? So that would be the good faith estimate. Unless, again, like a surgery, we know that there's going to be a certain amount of stuff. I think generally for therapy, psychotherapy, we're just talking about session-based price for service. Yeah, that's fine. Okay, what steps should be taken to document client consent for private pay extended sessions? I touched on that a little bit more before. I'm just going to look at see if there's anything that I didn't say. Yeah, I mean, you got to be careful if we're actively telling insured patients to go somewhere else. I think you just want to be very transparent as to, let's reframe that conversation as to, here's what's offered here, here's what's offered over there. I can't tell you where to go. That's your decision. So less of a forceful nudge and more of an educational, statement of fact. Great, cool. Towards the end, I'm going to leave that. I'm actually going to open up comments over here. Let me stop sharing so I can see the chat.
Kind of jumped around a little. At the top is Sheila Trablisi at 11:05 a.m.
Yeah.
It's kind of along the line with intensives. I get this question a lot. People are credentialed only with like Headway and Alma, But so they want to take insurance through Headway and Alma, but they want to be private pay in their private practice. And the understanding is it's totally fine to do that, but I get that question constantly because people, it's kind of a way to still take insurance, but not really have to always take insurance. You can kind of build your private pay practice over here, be credentialed under that tax ID and their MPI too, instead of your own business. So a lot of people will ask, how do I manage that?
And sorry, I was also skimming some of the other ones. So the question, as I understand it, is sometimes I want to use insurance, sometimes I don't type situation.
Well, it's kind of like if you think about it, like they're working for a group practice essentially, and they're credentialed under the group practice, but they want to have their own private pay practice on the side and not take insurance. Is it okay to do that?
Yes. Yes,
Okay.
it is. With the asterisks that, just want to run it through the usual, are there dual relationship rules? This would be at the ethics board, at your professional license, not state or federal law, although those should be considered as well. There's actually 3 layers. It would be, do I have a employment or independent contractor agreements, and also are those provisions valid? 2, what kind of professional license do I have, and are there potential ethics rules that apply? Sometimes there's dual relationship rules that could apply, and we're just, kind of SOL for those. And then the third would be any federal or state kickback self-referral rules. But generally, those are much more geared towards physicians and less applicable unless they've created basically the duplicate of it for other at the state level or for other professionals so yeah, those are the analysis there.
I'll let you take the questions if you want.
Yeah, I'm just going to go from top to bottom here.
Okay.
-25 in Illinois from Kelly. Yeah, it's actually negative something around here. We're getting up to a high of 10, but I think it's at midnight. There's a question here from April. Interested in how to bill for therapy intensive. Hopefully that was answered pretty thoroughly, and we'll have more context in the slides. No problem. Okay. Thanks for leading with a disclaimer. Thanks, Mel. Kathy, do we have to separate pay for clinicians into clinical and non-clinical hours? I think you're talking about into the context of billing. May need a
maybe
little
like
more...
employee, like maybe employee is like, do we have to separate pay for clinicians into clinical and non-clinical hours? So like
you could.
Okay.
Yeah. Totally allowable as a compensation structure to have, hey, you have your, talk to a CPA and probably a local, labor law attorney is the disclaimer. But I do this as well, as where if you're doing clinical work, that's probably reimbursed at some rate. If you're doing admin, marketing type stuff at another rate, it becomes kind of a, a payroll nightmare if you do it wrong. So you're creating different issues. I see Kathy, you've raised your hand. So do we unmute her, or how does this work?
Sure. Can you unmute?
Let's see.
Kathy,
I can view her.
she has control.
Yes. Hi.
Hi.
Yes, I asked that question. I was told with my employee contracts that I had to separate out clinical hours for reimbursement between non-clinical, such as writing notes, treatment planning. And so I've been doing that. I pay separate, but ideally I'd like to pay, give them 70% and say, this is for both clinical and non-clinical. And so I'm not calculating, all the non-clinical hours separately. So just check in to see if you have any thoughts on that.
Sure. Well, as a general rule, I think there's 2 different things going on, right? There's what you'd be reimbursed. I'm just going to put it in the context of insurance, right? So the service, you just get one rate, right? That includes the time spent plus the documentation. So maybe I'm misunderstanding the question, but that's all clinical to me as the attorney. Now, if you're saying non-clinical as in, I'm going to go out and do some marketing or I'm trying to think of other activities your staff might be doing, maybe like a daily huddle type thing. I could see that be reimbursed differently from an employment law perspective, which is a choice that the employer could make. I'll just jump to the next question just to try and get
Yeah.
through a couple more. Yeah. So
Sheila's is the one I already asked you about, Headway.
okay. Hopefully we got that one, Sheila. Lydia, interested in how to keep couples counseling off insurance when you're paneled with that insurance, not wanting to do 90 some billing code, which is less money for the individual session. Yeah. I don't have a good response to that one right off bat. Maybe.
This is a controversial question because technically to build the insurance, you have to have a primary client, an identified client, and then you have to give them a diagnosis and you have to bill under that client for the 90847 and the 90846. So, a lot of people make different decisions around this. If you're seeing a couple or, a marriage counseling, some people will use the idea of you can't bill for a couple or you can't diagnose a couple. So they will write off in their paperwork, say, I don't bill insurance for this because I'm not going to identify either one of you as the primary client. I'm going to have a Z code just saying like marital discord or whatever. And it's not a diagnosable situation because I don't want to give a diagnosis to either client. So some people will do it that way, but you'll hear other experts say, no matter what, if you're paneled with the insurance company, if you are bringing these people in and they have that insurance, you need to give the primary diagnosis and bill a code, the 90847, which almost always pays less than a 90837. So therapists hate to bill that code because it pays less, essentially. But that's my understanding of it. I'm not a lawyer.
Yeah. I'm going to punt on that one because I need a legal question on it. It sounds terribly unfair. I've seen it happen. Generally, you'll notice my legal advice also takes in the practical reality of being a business owner. So I'd probably advise some creative ways to, probably get compensated, but still serve this client and turn it less into a billing issue and more of a, I think being valued for your time. So I don't have a good answer for you, Lydia. Maybe you follow up with me separately. We'll see what we can do. I'm going to jump here. Kathy, sorry, I'm going to skip yours just as I already did one of yours. Brooke, we got the info. It's at the end of the slide. Race. Let's say that a client is claiming on their out-of-network benefits. They're paying the therapist directly, then submitting Superbills to the insurance company, and then the insurance reimburses the client. What happens in the case of the records request or audit where the insurance company determines that they want to recoup the funds paid? Does the company go after the client and try to recoup clients directly from the client? Yeah, you would. So in your patient consent form, you should have a nice little clause in a perfect world that says, at the end of the day, the patient's responsible for payment. I don't think that's that shouldn't come as a surprise. So we will play by the super bill, by the insurance, whatever we agree upon. But at the end of the day, this is a legal debt. This isn't like I slipped through the system so I don't have to pay. This is a legal debt. So would you go after them? You could. I'm rarely a fan of moving, depending on the amount, these types of bills to collections and things like that, especially in Minnesota with the recent Medical Debt Fairness Act, if I'm quoting it right, that made it much harder for those who carry a debt to deny services to them. But yes, you can. Is the short answer there, Grace. Hopefully that answers that one. What is the deadline for letting clients know about balances that they owe us? From Lucy. Lucy, I think you mean what's the deadline of alerting them that there's a debt? Probably. Is
think so.
how I'm going to take that question?
Like maybe they had deductible, like maybe you file a claim and then you find out later, oh, actually it was a deductible and they haven't paid me anything, or how much time do you need to give them notice that they owe you, basically?
Well, the payer contract will put their own timelines on when certain behavior needs to be done. State law could put an overlay on top of that as to when you need to alert somebody that there's an actual legal debt. So not fun, especially because you're just at the mercy of the, submitting things into the system. What's also interesting here is that if a patient doesn't disagree with the timeline and the amount, you could probably tell them anytime. And if they pay it, that's a private relationship. So got a New York question here from Kelly. Unfortunately, I'm not licensed in New York, so I can only speak in general terms. It's talking about clinical supervisors have to live in New York for supervision hours. My question is, can the agency supervisor who's licensed in New York but does not live in New York sign off on notes for billing? It unfortunately calls for specific legal advice in New York, so I have to skip. Matthias said to mute your mic. Thank you. Was mentioned we can schedule. Okay. Is waiving the fee similar from Julie, similar to being ghosted for payment with a card on file not working? Is waiving the fee similar to being ghosted? Yeah, I suppose that's maybe that was just a comment or a side note and not. Sorry, Julie, if I wasn't supposed to read that. Mela said, is it okay for me to have insurance-based private practice? Yes, you can have the separate practice. I think we hit that nail on the head. Insurance panels from Rana said, insurance panels ask what gender and age do you see? I say adult women age 18 plus or 18 to 62. I advertise therapy for women. Any problem with this? I don't. Although there are age discrimination rules, your professional competency supersedes that. So if I am not competent to serve people above 62, then I am not required to, accept them due to discrimination rules. So maybe that is the concern or the potential problem with that. If there was another one, I'd need more time to reflect on that one. From Sarah, hello, I hope to ask if it's legal to save a client's debit card and make a change in situations when they ghost or don't pay for any amount that is their responsibility. Absolutely. So I do like a financial, it's usually integrated into EHRs these days, but a little financial payment authorization. And they put in their payment authorization and it says, we can bill for your services and missed appointments per our consent document, which has a, nice, clearly outlined cancellation policy. So there is not like an awkward bill that goes out when they miss a no-show, no cancellation. We just run their card. And in addition to that, put a little bit of language at the bottom. And what we're trying to do is survive if they are, kind of a jerk and they challenge it with their credit card or their bank. We want to be able to survive that scrutiny in a chargeback scenario. So if they make a change to that, like their credit card, the credit card expiration date or anything like that, the payment method, we absolutely want to get that back on file. So it's just an auto charge. Is it okay for Medicare clients to choose to be self-pay? Yes, for Letty, if they fill out the ABN, Advanced Beneficiary Form. From Rana, again, can insurance panels with whom I have a contract drop me if I decide not to take Medicare and officially opt out? I'm going to punt on that question just because it is a little bit higher grade.
Yeah,
Julie
that's
asked,
kind of a controversial.
Yeah.
Go ahead. Sorry.
What if after signing they aren't going to use insurance and they go back and turn it into the insurance? So they superbill. So basically what you're saying there, after signing, they aren't going to use insurance, so they're self-pay, but then they turn around and go and superbill insurance. Insurance at that point is going to be confused, but you, per my advice, would have gotten a nice little document that said they chose to be self-pay. And if payer comes knocking on your door saying, why the heck did this patient submit the superbill? You'd be like, because the patient told me they didn't want to use insurance. So that's between you and them. And so that covers your butt in that unique scenario. Why they would do that, I don't know, maybe life circumstances change. I'm going to just text my assistants.
I know you're got in a meeting.
Yeah, it's just a daily huddle, probably similar to you, Kim, with the assistants. So I will shoot her a note and let her know, let's move our meeting.
Thank you.
I'm just having such a good time at this webinar that we let's move our meeting late in the webinar. There we go. Okay.
I think we kind of already asked this one from Kelly Branch Dirk. Is it okay to choose for Medicaid to choose self-pay? I think we already answered that. But.
Yes, I didn't have time to put up on my screen, but Minnesota has a lovely advanced beneficiary notice for self-pay.
So that's for every state. If they do that advanced beneficiary form, that they can be self-pay, or I know you're not licensed in every state.
Well, yeah, I'm only licensed in Minnesota and California, but I can comment on federal law. Medicaid is paid, in Minnesota, is a federal program, right? Matched by usually state dollars. And so states are allowed to put their own little rules on them. I would guess it'd be pretty similar in most states. It may become more of a, political thing across some state lines, but California and Minnesota absolutely allow ABNs. I can't comment on any other state.
Okay.
Mela said, let's say that a client is claiming on their out-of-network benefits, they're paying the therapist directly, then submitting Superbills to the insurance company, very similar to the previous question, and then the insurance reimburses the client. What happens in the case of a records request or audit where the insurance company determines that they want to recoup funds paid out after reviewing the provider's notes? Oh, did I already answer this one? Sorry.
I think you answered something similar. Yeah.
Yes. The company does go after them, but you would have had the very nice self-pay form that said, I was just following what the patient said, and the patient is king in this scenario. Their legal decisions trump me, the provider, and you, the payer. So if you got any beef, it's down with the patient. And you could go after that patient in that situation. From Emily, as some insurances over group therapy and offer group therapy that others do not, can I set a self-pay rate for those with insurance that doesn't cover that is lower than what I bill for this? No, just the retail rate. An anonymous iPhone asked me, can you do a sliding scale while credentialing with Medicaid? I'm going to punt on that one, but the assumption would be that the Medicaid individual actually showed up as a self-pay and opt out. And I'm guessing you're asking, can they then turn around and do a sliding fee scale? I'm going to punt on that one. I'm going to say maybe, since I'm being recorded. All right. Mel says, if a clinician is not in network for a particular Medicaid plan and a client with that specific Medicaid plan wants to pay cash, is this allowable? I think very similar to the question above. If a clinician is not in network and the client with that, yes, so it would be an opt-out analysis. Medicaid's really just the front for who's actually paying the payer, and in this situation, they opted out. iPhone again asks, oh, never mind. One was direct, one was public. Okay. Intensive billing from Zahira. Hopefully I didn't butcher that. Intensive billing. I think we answered the intensives with the separate entity answer. And or just very specific consent forms stating, where the limits are.
Yeah.
Nice, good fee schedule clarifying where the limits of the insurance billing is for intensives. Can you have, from Kelly, can you have a different fee schedule based on geography? For example, Massachusetts versus Georgia? Absolutely. Yeah. Across state lines, you absolutely can. Got to be very clear with that, though. If you're using one website and maybe one entity as a foreign entity registration, it's really, down to the particulars of when am I in Massachusetts, when am I in Georgia, when usually you're just sitting at your home office doing telehealth. The life workshop, okay, with that being said, if a particular insurance company has had issues like legal or payment disruptions that aren't at all client related, can we stop accepting clients while managing or seeing out those other issues? It's okay if that's the same answer you just gave.
I think they might be talking about Change Healthcare, maybe, and how they had that breach and nobody got paid, and you couldn't see, you had to see your clients and still bill the insurance, but you couldn't bill. I'm thinking that's what she's talking about, but I'm not sure.
Got it. yeah, it's basically you're upset that they're screwing with your payments, but you still have the contract with them. They're still sending people to your door. Do you have to see them?
Mm-hmm. Or can you say, look, I can't
The
see you? Or can you
contract,
say, you got to be private pay because I'm not getting paid by the insurance company?
yeah. Well, and this will be good, just broad, although this may feel unfair. A contract is still valid until somebody calls in the breach, right? So I would say that was definitely a breach that was, kind of called in a very roundabout way, or lack thereof. But everything's still in force until one of the parties says they're not, or there's a breach or something else we can point to. So yes, you would still, maybe you just call in the breach. You say, you know what, I'm done. I actually don't really care what the contract says because you're so far in breach, the notification doesn't apply anymore. We are now in the Wild West. We're superseding the contract terms because you've breached so badly. I need to protect my own, livelihood.
Yeah, because
But
we hear
I
that
mean,
all the time. Like somebody will say, United hasn't paid me for 6 months. Like they're refusing to pay me. They're saying I'm out of network, but I'm actually in network and they're not paying me. So stuff like that comes up a lot. Yeah.
yeah, and they're leveraging we're going to close the door on the patients if you are saying we're out of network.
Mm-hmm. Exactly.
Okay.
Yeah.
Yeah,
Thanks.
tough situation. Rebecca, I know several therapists who are charging significantly lower self-pay rates for sessions that are being called consulting instead of therapy sessions. Are there any cautions you advise in doing this? What legally defines the difference between consulting and therapy? Ooh, great question, Rebecca. So I would say, and I've been tiptoeing this line between legal advice and educational, and I think professionals will often do this, but it's definitely dangerous to do. What I would say is, let's assume, as we're being, recorded now, as I'm being recorded, if I was in a consulting session versus a therapy session, what would actually be different, right? So, am I doing diagnostic type things? Am I, really analyzing and making, clinical type decisions? That's, even if I call it consulting, is not going to be consulting, right? And as you phrase the question, it looks and feels like they're doing the same thing and just relabeling it. That doesn't work. So there would have to be, but I will take this in a positive direction. You can purposely dissect, the service that is therapy and take out some of the clinical components. This generally happens in like coaching or high performance, consulting, and organizational, whatever, the buzzword is. And that is absolutely okay. And then we have a nice disclaimer: this is absolutely not therapy. We are not going to be doing all the things that look and feel like therapy, like diagnosis, treatment, what have you, billing to insurance. And so that's where you can get a little creative with maybe packaging the things that you'd prefer to be doing, maybe high performance coaching, into a different entity and or a different service line. So I would not recommend, though, just relabeling and charging differently. That would put you at risk for your contract. The life workshop: is it legal to have in our policies that we will not ever back bill insurance? If a client doesn't notify us of an insurance change and we find out when we're billing, etc., they give us new insurance afterwards, can we state that we will not retroactively bill due to their failure to notify? It would actually go back to, what are the limits of the actual payer for the respective new insurance for how long you can back bill. So yeah, you could do that with the patient, but you may unfortunately be in violation of your contract with the actual payer. So it would go back to that. And, to be honest, I would call the respective payer and ask how they want to handle the situation. But is it legal? I mean, when we're thinking of, what's legal in a payer provider contract, a lot of that is going to go down to the actual written four corners. It's not like we have this, beautiful and easily summarized, payer provider law in each state or at the federal level. It's just kind of broad insurance guidelines for, fraud and a few other things. Okay. For Zahira, hopefully I'm pronouncing that right again. I got credentialed in insurance when I only had a license in my state. Now I am licensed in another state. Does the credentialing apply to the second state, or is the contract state-based. It would be state-based unless stated otherwise. Stacy, if I charge full fee for no-shows, should that be in my retail rate? Should that be at my retail rate or at the insurance reimbursement rate? Good question. So I would do it at the retail rate. So that is some people might feel like that's a little harsh. You don't have to charge the full fee. My viewpoint is the reason I'm charging the full fee, very, Adam Smith or whatever of me is, that is the price that the markets would pay to fill that position. And they've robbed you of the opportunity to offer that out to the world. And so, the beautiful, market or terrible market, however you view, the market that's what it would pay. So we don't pay what the insurance would pay. That's just what this particular individual would have done. We charge the higher rate. Now, for practical purposes, maybe your rate is not the full market rate, but that is allowable. We need a different tax ID for Julie. We need or separate websites. I think that was related to when we were in the slides, and I said yes. Yeah, I said yes. For Buffy, are we allowed to just create it as a separate service or alternative service that clients know which one they're signing up for at the beginning? For instance, if a practice has other services like nutritional therapy, gut health testing, or day-long immersions as well. Yes. So, the analysis again is, what am I coming in and buying? I think this was a tail end of the intensive services discussion. You can have a whole fee schedule. You can be a multidisciplinary practice. Absolutely okay, so long as I, the patient, understand, what's covered by insurance, what's not, what are the prices. But creating separate services, I don't know what you mean by alternative service. I suppose you mean.
I think she's probably talking about intensives too, or something like that.
Okay.
It's such a gray area when it's therapy still. I think that's where the gray area is. If it's gut health testing, you're not like a doctor. You probably couldn't bill for that, obviously. But these day-long immersions as well. That's where it gets in that gray area because it's still therapy. But it's like everything David already talked about. I think is like, if you've got the insurance contracts, you need to check with them and see how you're supposed to bill them and all that good stuff, right? I don't want to talk for you, David. Just trying to interpret.
Oh, you're good. I'm on to Mel here. Let me just take a peek at my calendar.
Let us know if you got to go. We got 44 new messages under this one. You tell us.
Okay for now. Do you need to let the call center know that you're recording the calls? Actually, a fun state question. So Minnesota, for example, we're a single party consent state, which means only the person recording needs to actually know that it's happening, which, doesn't really help because you could be, secretly monitored. It's also one of the reasons, as a sidebar, that for my Minnesota clients, I always put in a provision that we do not consent to any recording, video or audio, unless we separately agree for like a review or something like that. This is to prevent the, phone in the pocket and they're trying to catch you and, send it off to some board or God knows where. So in Minnesota, we would not need to announce that. We just start recording. Not all states are like that. Some are two-party consent states. So as a general rule, I would say if they announce, you announce, because they probably have got legal advice and are following the local law. They know what location you're at. Or conservative advice is just tell them you're recording. I wouldn't expect different service because you're recording. I sure as heck hope not. But conservative advice would be alert them. But some states do not require you to do so, like Minnesota. You can record phone conversations with the provider rep. Yes, you absolutely can. And this is the private business-to-business relationship, so just usual recording would apply. They're also likely recording you. Zahira, again, I probably pronounce it 3 different ways for each question. So thinking about having one insurance business and then private pay business, isn't the provider credentialed with insurance and that applies for both businesses? No, it's actually specific. You'll even see on the provider contract, you put your company. We don't put you individually, or at least I hope we don't put you individually. And so it should be a relationship or a B2B with the company. Hence why we can do the intensives in one company and not in the other. And why we actually do that. Maybe you're getting handling and credentialing a little bit. Maybe that was what made that. But Julie Johnson Counseling and Coaching is my business name, website, and clear on the differences. And I am clear on the intensives and workshops. Should those be separate? Ohio, Florida, South Carolina, licensed therapist. I do some insurance and some private pay as a therapist. You can group counseling and coaching together if you'd like. I have there's pros and cons to both of these analysis. Like, do I put my coaching in a separate business? Do I keep it in my therapy business or professional services business? I think there are pros and cons, and as I touched on a little bit before, the big question is what's different between your coaching and your therapy. I've counseled some clients where what they were doing, I felt like working with like high performance individuals. It was still therapy. We just kind of had that nice little entrepreneurial flair that brought it to the next level, I would say. So the reason I like them just calling that counseling or professional services is because I would just alert my malpractice carrier, hey, these are all professional services. I expect them to be covered in the case of an event. I don't have to go and have another service line or another business that I then need to insure as well. And so there could be some pros in that scenario. I guess the only thing when you're using the same name, counseling and coaching, is I just need to know when am I with you as a counselor and when am I with you as a coach? Because the record keeping and confidentiality rules are going to be vastly different for both. And I need to know when I'm moving over the lines, but I can't comment on any of those states that you made. Although I will say, in general, coaching, licensure, credit, or lack thereof across the entire nation is pretty loose. Fiona, just joining due to scheduling conflicts. Will the webinar be made available? I believe it will, Kim, right? Online?
Mm-hmm. Yep.
Great.
We're going to send out the replay. Yep.
Nice. Or vineyard or vineyard counseling. Sounds fun. I'm licensed in 2 states, Arkansas and Missouri. What is the insurance rule for billing locally? Unfortunately, I can't comment on local state rules, so I have to punt on that guy right there. Chandrea, I am contracted individually with an insurance, but I accidentally billed through my company, which is out of network, and they offered me a higher rate to settle for the service. Is it wrong to accept payment? Really interesting. I need to see more details on that one. That is very interesting. And also a pleasant surprise, perhaps, to figure out what is going on there.
Huh.
I see Deanna has raised their hand. I'll pause on Robin here. Deanna, do you want to go quick?
I do. Can you hear me okay?
Yes.
Okay. I want to stop taking insurance, but I have clients that I'm serving well under insurance policies that I don't want to terminate them. And so one thought in my collective was to get another tax ID and I don't know, not have to break up with my old contracts, but new clients under the new tax ID, just telling them I don't take insurance. And that sounds a little bit unethical or even fraudulent. So I'm just wondering what your thoughts are about that.
Sure. Well, it wouldn't be fraudulent. Fraudulent's a very high standard. It means you're doing something wrong, but you still do it anyway. As bifurcating and you taking insurance in one practice and you not taking insurance in another is completely allowable. Again, your gut may be right though on is it unethical? We'd want to do a quick check of your respective professional rules in your state, and then just a quick check. Sometimes states basically do a patient self-referral law that mimics what physicians or MDs have to do at the federal level, and so that can make another layer of considerations. But I'm not hearing anything fraudulent based on how you set that up. There could be dual relationships at the professional level, so there's an analysis, but on its face, seems viable.
And I can keep my old contracts. I won't have, like, that was the thing. It's like, I don't want to break up with all those old contracts, but I kind of want to try to build a fee for service practice and then eventually let that go.
No, yeah, you do not need to break up. As
Thank
that's
you.
the whole point. Yeah,
All right. Thank you.
yeah. We'll do maybe 5 more minutes here. It looks like
Okay.
somebody's pinging me to get into something
Can
at
I-
11:30, so I will do that.
Okay.
Can I
West
can I ask a
Virginia
question
from-
related to that last question?
Yeah, sure.
Sure, Ginny.
So does Medicare create a different issue with that? So if I have an insurance-based private practice and I am opted in for Medicare, and then I have a separate private pay private practice, do I also have to accept Medicare?
Yes. Medicare is is professional specific, unfortunately. So that's one of the annoying ones.
Mm,
Okay,
great
thank you.
question.
Yeah.
Attorney Holt, can I ask one? This is Grace, and I had asked a question before about out-of-network benefits. So if a provider is audited and the insurance company decides that they don't like the provider's notes or decides that it wasn't legitimate services for whatever reason, does the insurance company then go after the client for the funds that were paid to the provider by the client, if that makes sense? So the client pays the provider, submits a super bill to the insurance company pays the client, like reimburses the client.
I think it's whoever they paid the money to, right, David? If they pay the client because the client submits the super bill and the client gets paid back out of network benefits.
Well, there's two
I don't know.
separate but very related legal things going on. One would be for any poor record keeping, your contract with the payer is at risk, right? Maybe that's already obvious. So even if the payer is going after the client for the money that they feel like they overpaid on the super bill submission, we still have the separate and distinct record keeping rules. So, which I think was you're saying the audit showed that the record keeping was poor, right? And this should not have been built in the first place. So,
But the clinician's out of network, like the clinician's not even in network with the insurance company, I think is what she's saying.
Right, yeah.
clinician is out of network.
Yeah. So there's no
Well,
contract with
you
the
have
insurance
no
company.
contract. So you have no contractual relationship with the payer. So absent some state rule, I don't know what their legal cause of action would be against you. You don't have a nice signed written contract. So their super bill, overpayments, that would have been with the patient directly, not with you.
Yeah, like in the case if the insurance company decides that the services were non-covered, and they paid the client already, and they're like, oh, we don't want to pay this anymore.
Yeah.
But
But-
yeah, no, that answers the question.
To play devil's advocate, the patient may have a cause of action against you for not having documented the services correctly, for which now they are not, if I drew the web correctly, but for which now they have to work around with the insurance company in this scenario.
Right. Okay.
Yeah.
Interesting.
All right. I think I'm going
I
to
know we're
pause
at
it
time,
there.
David.
Yeah,
Yeah,
yeah.
thank you for going over by half an hour. That's amazing. Thank you
Yeah.
all for coming. David's a great resource. Like I said, I use him for my own legal stuff. He's super helpful. I would say reach out to him, especially with these really specific questions. And yeah, this is normally a Bill Like a Boss presentation that we would do only for Bill Like a Boss members, but I'm glad I was able to bring it to everybody. Coming up in 3 weeks, we're having another exclusive Bill Like a Boss presentation that's just around billing for neuropsych testing, ADHD testing, and all of that stuff. So if you're not a Bill Like a Boss member and you're interested in that, come join us over there. We'd love to have you as a member. And David, thank you so much. I really appreciate it.
Thanks for hosting. Thanks for having me. I'll sign off, and thanks for those who ask their questions and were brave to do so. And
Thank you,
sorry to
everybody.
those I couldn't get to. Have a great rest of your day. Thanks,
Bye,
everybody.
everybody. Bye, everyone.